A few words about some clinical considerations. You all know vital signs, right? So we measure two cardiac vital signs: the pulse and blood pressure. And the pulse, that's basically the difference between systolic and diastolic pressure. So we measure pulse where large arteries run against something solid like a bone. Okay, so the most common, really, radial, you can do brachial, common carotid, and temporal. When I was a kid, I was fascinated by measuring my pulse. Here, it just seemed so convenient. I could never measure it with my radial artery. You can do it others. Just depends, which body side is more accessible. Now, how do you measure systemic blood pressure? I kind of feel that story is a bit outdated, because now you go to Walgreens or CVS, buy the electronic manometer, and that's it. Now, the old school use the manual sphygmomanometer. You apply a cuff. You'll know what I'm talking about, right? Apply a cuff. Generally, you apply it on the brachial region, but you can do it in the leg as well. What's the ideal position? Ideal from physiological standpoint. It's the neck. It's the closest to the heart. The closer to the heart, the more precise your measurement is. The only problem with the measurement of blood pressure at the neck is that you likely have 0 by the end of the measurement. Okay, because you're going to suffocate the patient. So we're measuring the brachial artery. Really, it's as close to the heart as can be. Okay. So the cuff pressure, there's a kind of a mistake on the graph here. I'm going to point it. So there's your cuff pressure. You start with a cuff pressure higher than systolic. When cuff pressure and systolic pressure are the same, you start hearing so-called cortical sounds. It's a systolic. Then you hear them. Now, at some point, this dashed line is mispositioned. When cuff pressure becomes lower than the sounds right here, it should be a little bit to the left. So this is when cortical sounds disappear. You don't hear anything. That's your diastolic pressure. It's actually fairly easy to do. I believe many of you have done it. Yeah. And I noticed that in doctors' offices, now they use mostly old school traditional sphygmomanometers. The only difference is that the manometer is mounted on the wall. That's it. Yeah, I believe so, because I don't know what the mechanism for electronic to read the sounds, but I bet it's not ideal. And you can regulate the how slow. Thank you very much. How slow you release the pressure. I was trying to find a single word, but couldn't. How slow you release the pressure. Yeah, so it's very accurate. Now, blood pressure all changes. Like when you're running, your blood pressure is really high. You're exercising, your blood pressure spikes. I don't know if I mentioned, but you may have encountered Dr. Nussbaum. Here, he's department head now. I'm not gonna talk shit about him. No, but he's a. Oh well. Okay, thank you for permission. No, he's a power lifter, and I'm a runner. So two absolutely opposite activities. So he shows me clinical studies showing that running is bad for your health, and I show him studies showing that powerlifting is bad for your health. And actually, there was a study showing that cerebrovascular incidents in powerlifters, the hemorrhagic strokes, are more common than in regular folks because of the higher blood pressure spikes during the strenuous activity. On the other hand, there is a chronic kidney injury in marathon runners, and which is totally conceivable. And one thing that nobody understands why, but coronary atherosclerosis is more common in marathon runners than in recreational runners. It's kind of weird. But if you run a lot, your heart is not getting healthy. Okay. Now, definition of hypertension. Sustained blood pressure 140 or 90 and above. Prehypertension. Anything between 120 to 139 systolic, 80 to 90 diastolic. 120 over 80 and below is considered to be normal. Okay. Why hypertension is bad? Increased afterload, people. Increased afterload means heart failure. High blood pressure will affect kidneys. This is why runners have kidney damage, because of sustained blood pressure. Will affect kidneys. So renal failure. Vasculopathy. Increased blood pressure increases, it kind of stimulates inflammation in the blood vessels in general. Okay? Atherosclerosis, yes, stroke can be hemorrhagic stroke, for instance. There are two types of hypertension, primary and secondary. Primary hypertension is like, I don't think, my mom's hypertension. She has primary hypertension, well controlled. It's a chronic disease. If you control hypertension, the life expectancy for people with well-controlled hypertension is the same as for people without it. It's typical chronic disease. But it's genetics, it's age, maybe lack of exercise, undertraining, obesity, metabolic syndrome, stuff like that. Okay? So how you control it, you decrease the consumption of salt, you quit smoking, you take antihypertensive drugs. FYI, most efficient antihypertensive drugs are diuretics. It was shown in terms of like cardiovascular events prevention, diuretics do the best job. There are calcium blockers, beta blockers. They're all good. I mean, they contribute to the control of hypertension, but in the long-term perspective, diuretics are the best. Yes?
So, say somebody is on a stimulant, like for, I don't know, maybe they have they drink a whole bunch of caffeine, or
Yes.
for medical purposes, like they have narcolepsy or whatever. Usually your heart rate is really high,
Mm-hmm.
and with that, like your BP would be higher.
Great question. What will be adjusted if your heart rate increases? Will your cardiac output in the long-term perspective, will it change? Not really. If so your heart rate will increase initially, and then it will either go down or your stroke volume will decrease. So your heart,
basically adjusts,
yeah.
and that becomes your new normal. People who are runners and have like freaking 50 as their heart rate.
So for runners, it's a different story. So if you really athletic, not necessarily a runner, swimmer, any kind of, athlete person, your baseline heart rate will be, say, 50 or 45, which means your stroke volume will go up, incredibly. But if for some reason this person will have heart rate elevated from 50 to 55, 60, stroke volume will get adjusted, so the blood pressure will remain the same. Does that make sense? We're talking about maybe increasing heart rate from 50 to 120. That's a different story. That's definitely exercise issue. Or epinephrine, norepinephrine issue, stimulation, stress response. Does that make sense? But you brought up coffee. There are no conclusive studies showing that coffee is either good or bad. We don't really know. There were cases, at least one, of a person dying of a caffeine overdose, but that was IM caffeine, injectable caffeine. The high school student bought caffeine online. You can do it. At least you could do it. And during the exam season, was using it to stay awake, essentially overdid it, had heart attack, died. Yeah, you can do it. You can buy, I don't know, now I think it's tightly regulated, but it used to be you could go online and buy medical grade caffeine and inject. And that,
I thought I was making a joke whenever I said I need like a bag of coffee and like IV bag to stay awake. I didn't even know that was an actual thing.
well, not IV. Well, I mean, you probably can do IV. It's kind of requires a bit of a training, right? But IM was really easy. So yeah, you can do it. But you cannot possibly consume that amount of coffee to get that hyped, unless you fry from Futurama. That's a different story. And there's no link, for instance, coffee increases risk of cancer, coffee decreases risk of cancer. There are studies going both ways. So, not really. Now that's primary hypertension, like hypertension. Secondary hypertension is like kidney failure, specifically kidney, say glomerulonephritis, or stenosis of renal arteries, or Cushing's, increased production of cortisol and increased blood pressure, stuff like that. So in Cushing's, you control cortisol levels, you control the blood pressure. In renal stenosis, you dilate renal arteries, you decrease blood pressure. Hypertension. Blood pressure 90/60 and lower usually is not a concern, but it's a fine line. Like 60/40 and you won't be able to function. Okay? Is that a medical concern? It's actually an interesting question. Some people with hypertension would legitimately complain about being sort of sleepy, okay, and kind of weak. Why? So let me tap a little bit into the evidence-based medicine. How do we know that this is bad, 140/90, and 130/85 is not as bad? We have large, enormous cohort studies. We'll look at people's blood pressure dynamic over years, and we'll look at the risk for developing cardiovascular disease. And we can say that increased blood pressure increases the risk of cardiovascular disease. Does that make sense? Now, next question. Who said that 120/80 is good? The answer is, nobody really did show any conclusive evidence that's ideal. More and more clinical studies point to the fact that if your blood pressure is lower, say 110/70, 100/70, you have lower risk of developing cardiovascular disease than people with 120/80. Does that make sense? So if you, through exercise, say, for instance, diet, reduce your blood pressure, you have lower risk for developing cardiovascular disease. Which brings up the question, should like my blood pressure is about like 115/70. Should I start taking statins or antihypertensive? We need to address risk benefit. So if I take statins, what will be reduction in cardiovascular disease risk for me compared to the risk of side effects from statins? Does that make sense? These studies are virtually impossible to run because you can't justify the study on the hypertension treatment, but you can barely justify the study on let's give these drugs to healthy people and see if they're going to be more healthy. I mean, you don't really have any serious substantial evidence to do this. Does that make sense? It's kind of... Now, what can cause hypertension? Addison's, hypothyroidism, nutrition problem. An acute hypertension is usually due to the shock. And shock, I'm going to focus on some hypovolemia, low blood volume, vasodilation, okay, or vascular obstruction. Now, this is actually a fascinating story. So first, it's basically an overall review of the regulation of blood pressure here. So if your blood pressure drops significantly, what's going to be your baroreceptor response? Think about this. Blood pressure drops, stretch of the vessels decreases. Are you with me? It decreases, the baroreceptors will stimulate cardioacceleratory centers. Cardioacceleratory centers will increase cardiac output via elevated heart rate and elevated stroke volume. You with me so far, right? Vasomotor centers will be activated. Sympathetic stimulation, all that kind of stuff. So, peripheral vessels will get constricted, which will bring your blood pressure even higher. So let's say you lost 1.5 liters of blood. Still compatible with life, but you feel pretty crappy. So first of all, what's going to happen to your heart rate? It's going to go up. Tachycardia. What's going to happen to your peripheral blood vessels? They're going to constrict. Now let's figure out which blood vessels will constrict. Do you need skin at this moment? No, you don't. So blood vessels in the skin will constrict. You will become pale. Good? Do you need to pee at this moment? No, so renal blood vessels, renal arteries will constrict, meaning we're going to call it like no diuresis. I'm blanking on the proper term to it. Okay, does that make sense? So does
that mean like you'll retain water?
Yeah, one of the mechanisms. So there are several mechanisms through which you're not going to pee. One of them, constriction of the blood vessels. So blood will be diverted from kidneys to everything else, like brain, because you need three things. In this case, you need lungs, heart, and the brain. Everything else can wait. Does that make sense? So we got this out. What about endocrine responses? Blood flow, you lost, remember, 1.5 liters of blood. More than a quarter of what you have. What happens to the blood supply to the tissues? Decreases. What does that mean in terms of the carbon dioxide concentration in the tissues? Increase. Speak up, I can't hear. So CO2 goes up, which means, so tissue CO2 goes up, which means tissue pH also increases. Does that make sense? Wait, hold on. Not increases, decreases, becomes more acidic. Tissues become more acidic. pH goes down. Does that make sense to you? You with me? Now, that's going to provide additional feedback loop to increase your heart rate and vasoconstriction of unnecessary vessels. Does that make sense? Remember, chemoreceptors will be stimulated. We're good? Now, what about renal response? Which hormone is produced first in response to low blood pressure? Hormone produced by kidneys. Renin. And renin will stimulate the formation of another one, conversion, angiotensin. And angiotensin will stimulate two more. Aldosterone, which will retain sodium in water. So we can say renin is up, angiotensin is up, aldosterone is up, and another one, ADH is up. So angiotensin and ADH and aldosterone, they will all, well, mostly ADH and aldosterone, will stimulate thirst. So we'll start drinking water. Does that make sense? Angiotensin, the word angio, what does it refer to, anyone? Angiogram in the hospital. When they do angiogram in the hospital, what are they looking at? Vessels. Angio refers to blood vessels. So angio, now break it down. It's a, how to say, the compound word. Angiotensin. What does it do to blood vessels? Angiotensin constricts them. Not only it stimulates aldosterone, it also leads to vasoconstriction. Does that make sense? ADH, it does retain water, but another name for ADH is vasopressin. Vaso refers to blood vessels, pressin, compressing, also vasoconstriction. So ADH and angiotensin will lead to vasoconstriction. Does that make sense? So these are your endocrine responses: ADH, angiotensin, aldosterone. EPO, erythropoietin, much longer response. Does that make sense? So in this hypothetical situation, when you lose 1.5 liters of blood, if you stop bleeding and you can recover the fluid, you should be fine. You will survive. You will be tachycardic. You will be pale. You will not pee. Okay? You will have dry mouth because blood will be diverted from your oral cavity, basically. But you will survive. What's going to happen if you lose too much blood? You go into shock. Blood pressure is so low that blood flow to the heart through the coronary circuit is not sufficient to maintain cardiac activity. Does that make sense? If it's not sufficient, heart cannot beat well enough, blood pressure falls even farther, which reduces the contractile capacity of the heart even further. You have that positive feedback loop. Patient's toast. This is the blood loss problem. Vascular shock. That's the typical problem after the systemic allergic response. So when people are allergic to, peanuts, right? So they usually have two components of anaphylactic shock. One is anaphylaxis, the constriction of the bronchioles. So they start to suffocate. And problem number two is release of histamine from virtually every histamine-containing cell in the body, leading to vasodilation of all blood vessels that can vasodilate. That massive vasodilation, how does it affect peripheral resistance? Decreases. Decreased peripheral resistance, how does it change blood pressure? It drops. It drops immediately. Dropped blood pressure means blood flow goes down, meaning tissues do not get perfusion, person goes into the shock. Does that make sense? The vascular shock is pretty common in the variety of inflammatory diseases, something that is really close to my heart. Infections like Ebola virus infection, yellow fever virus infection, dengue virus infection. People die from massive immune response. Okay? Same goes for, well, we'll talk, cardiogenic shock. That's kind of boring. Heart cannot pump well, so blood pressure goes down. Same story. Okay, that's just dysfunctional heart. Now, something that is really close, sepsis. What's the problem with sepsis? You have two components. One component, sepsis is basically massive immune response to bacteria all over in your blood vessels. Sepsis means that you have bacteria in the blood in enormous amounts. You with me? So your immune system releases that histamine crap and blood vessels all over the place dilate. So you have vascular shock. Following? On top of that, due to some activation of platelets, your blood starts to clot. But it doesn't clot in massive chunks. It's called DIC, or disseminated intravascular coagulation. So all over the place, in tiny small vessels, you form tiny little clots. How do you think it affects perfusion? Not good, right? It blocks the blood flow. Now, that's the most fascinating feature, my favorite feature. When all those tiny little blood clots are formed, your blood suddenly becomes super liquid because all coagulation is taken away. Does that make sense? And that non-coagulating plasma starts to seep through walls of the blood vessels into the tissue. How do you think that affects the blood volume when plasma starts to leave blood vessels? It goes down. So you have vascular shock and hypovolemic shock at the same time. And in fact, in diseases like that, in sepsis, for instance, often you have to supply IV fluid, just a fluid, to maintain the blood volume. It certainly helps in infectious diseases like Ebola or yellow fever. Just the IV line with the saline increases the chances for survival. Does that make sense? And there is a song actually that is called Disseminated Intravascular Coagulation, produced by progressive death metal band called Viremia. I strongly do not recommend to listen to it. It's basically a torture. No, seriously. I mean, I can go through about 15 seconds of it. Then it becomes unbearable. Huh? Oh, you go on YouTube, Google disseminated intravascular coagulation. It's one of the first things in the search. They actually have a live version of it. Like, they actually have I don't really understand the point. It's a bunch of people seemingly playing instruments in very asynchronous manner, and the guy that's fine. It sounds like somebody's raping a goat with a pneumatic drill. My wife usually compares them to like they vomit in the microphone. It's very interesting sound, but I believe people listen to it, and it's actually, if you look at the technical part, it's extremely technical. Like, it's really complex, but parts of different instruments, they don't seem to have anything in common. Okay. Now we're not gonna finish today everything. So what I want to do, we're gonna chat about tissue perfusion a bit today. And on Thursday, we're going to finish tissue perfusion. We're going to go over the study guide. We're going to go over the quiz that I'm going to give you today, which involves some of the tissue perfusion. We'll kind of finish it in class, okay? And we will go over some of the concepts, more of a hands-on on Thursday, okay? So we all comprehend cardiac output, blood pressure regulation, stuff like that. Deal? So, blood flow through the tissues. Delivery of oxygen, removal of carbon dioxide. It turns out those things, CO2, oxygen, and pH, are three main parameters that govern tissue perfusion. Okay. one of the underlying principles, flow matches tissue requirements. What does that mean? Here's your skeletal muscles, the baseline. All skeletal muscles have about 1.2 liters of blood delivered to them every minute. When you perform strenuous exercise, playing soccer or basketball or lifting, the blood flow to the muscles increases tenfold, from 1,200 to 12,000 milliliters a minute. Because muscles do the job. Does that make sense? For instance, if you would compare the blood flow to your brain when, I don't know, you're not thinking, and then blood flow to your brain when you're thinking, blood flow to the brain when you're thinking about something, doing a task, will increase. Does that make sense? We kind of mentioned that, but blood flow is fastest in the arteries, slowest in the capillaries, somewhere in between in the veins. But the majority of blood, like the highest cross-sectional area, is in the capillaries. This is why the blood flow is the slowest, to facilitate the exchange. So actually, tissue perfusion, now you have to understand, hold on, so when you have a tissue perfusion issue, you kind of have to counteract it with the blood pressure. Okay, what is more important? A perfusion of a localized tissue or the maintenance of the systemic blood pressure? Blood pressure is more important. So during blood loss, intestines, stomach, skin, nobody cares. Does that make sense? Brain, heart, lungs to a certain extent. Okay. Maybe muscles to some extent, just to move around. Everything else shuts down. Because blood pressure is the key, yes?
So that's why, like, people who have sepsis or septic shock, that's why, like, their fingers and their toes start turning black, because there's lack of blood flow to the lower extremities and stuff.
That's a tough question. In sepsis, there's a lot of... So if you have bacterial sepsis, it's really hard to separate the coagulation part, obstruction of blood vessels, hypoxia, and maybe even gangrenous events, from effects of infection itself, from lack of blood flow. So it's all together. Yeah, because if somebody is septic, now that, again, that is close to my heart as microbiologist. If somebody is septic, it means you have bacteria in your blood twice a day when you brush your teeth. You do have bacteria in your blood. In sepsis, they replicate in your blood. They grow there. They reproduce. Your immune system is like, holy cow, it goes all 100% out and cannot kill them. And your immune system going 100%, it's not good. You're going to die. Okay? Does that make sense? So it's, in this case, it's going to be multifactorial. Say a typical sign of septicemic bubonic plague, black toes, black fingers. Because cells getting killed by Yersinia pestis itself, lack of blood flow contributes, and intravascular coagulation contributes. So, when we're talking about the control question,
We're talking about toxic shock. Yeah.
same.
Same thing.
It's sepsis, yes. It's just a separate name for it, but it's sepsis. Yeah. It's just caused by a couple of specific bacteria. It's absolutely the same. So when we talk about tissue perfusion, we talk about local events, controls that are independent of systemic blood pressure regulation. Let's take exercise as an example. When you exercise, which organs are of the primary importance? No. When you like jump and run and lift, muscles. So the majority of blood will be diverted to muscles. Does that make sense? Stomach, intestine, liver, nobody cares. You're not going to poop. You're not going to digest. Nobody cares. Does that make sense? You just ate. You had a great lunch. You're sitting in the chair reading a book. You need to digest now. Blood will be diverted to the digestive organs. Does that make sense? Your blood pressure, say you're walking and you're digesting, your blood pressure is not that different, but the direction of flow will change. Are we clear? So we presume in this conversation that blood pressure remains fairly stable. So controls can be metabolic. Metabolically active tissues will produce a lot of carbon dioxide. That a lot of carbon dioxide will decrease the tissue pH. Does that make sense? And they produce carbon dioxide because they respire actively. And since they actively respire, the oxygen levels decrease. Chemicals that are associated with increased metabolism, elevated potassium, adenosine, prostaglandins, and kinins, they are also chemicals of inflammation. This is why blood flow will increase not only to metabolically active tissues, but also to inflamed tissues. Does that make sense? Now, let's forget about inflammation for a second and talk about metabolic controls. Your muscles, during exercise, use glucose in the process of cellular respiration, produce CO2 using oxygen. Are you with me? So blood will be diverted to them in response to these chemical cues. Does that make sense to you? Do you understand the idea? So elevated CO2, decreased pH, decreased oxygen, they will all increase blood flow to the tissue. Got it? Myogenic controls. Same idea of negative feedback. So in myogenic control, if it's easier for me to show it using my hands. So that's your blood vessel. Okay? Imagine that you have a spike in systemic blood pressure. What's going to happen to the stretch? Initially, right? That's a response to the spike in the blood pressure. You see? The vessel dilates initially, stretches out. Now, that increased diameter of the blood vessel in response to the spike in the systemic blood pressure, how will it affect flow to the tissue? It will increase it, but tissue wants to maintain it, right? So response to stretch will be constriction. Response to lowered blood pressure will be dilation. Does that make sense? Do you understand the idea of myogenic controls? Increased, look at my hands, increased stretch due to blood pressure leads to constriction and maintaining the same blood flow. Decreased stretch leads to dilation and the maintenance of blood flow. Both mechanisms, metabolic and myogenic, will play the role in regulating blood flow in a tissue. But different tissues will use different controls to a different extent. For instance, in muscles, the main mechanism is metabolic. By all means, it's metabolic. In the brain, it's slightly different. We're going to chat about it. Do you understand? So you have to understand that metabolic and myogenic controls are immediate ones. You understand what? So immediate ones meaning they respond like in a second, if not less than that. Long-term regulation is angiogenesis. Angiogenesis can be good. Say, if you exercise regularly, your heart will require higher blood flow. Following me? How can it be achieved in the long-term perspective? You literally grow new vessels in the coronary circuit, increasing perfusion of the heart. When people's body size increases, and actually whether it's muscle or fat, the number of blood vessels will increase. Interestingly enough, the adipose tissue has less blood vessels, lower angiogenic potential than muscle tissue, because adipose tissue is not as metabolically active as muscles are. And sometimes angiogenesis isn't good. It's a case of cancer. Cancer cells are very interesting metabolically. When tumor starts to grow, cancer cells usually switch to very high rates of metabolism, and they grow extremely fast, and the tumor growth isn't matched by the blood vessel growth. So that leads to hypoxia at the center of the tumor. Does that make sense? Hypoxia at the center of the tumor causes cells to produce so-called angiogenic factors, which stimulate blood vessel growth. So tumor essentially releases chemicals, the factors, that stimulate the growth of blood vessels into the tumor so it can have a better oxygen and nutrient supply. Does that make sense? A lot of drugs that are now employed to stop tumor growth are called anti-angiogenic drugs or angiogenic inhibitors. They essentially inhibit the growth of blood vessels into the tumor. And, they work to some extent. They're not killing the tumor, but they're basically trying to suffocate it. Okay? So, we're going to wrap it up. We're going to finish it on Thursday and do a bunch of